Hello everyone. The topic for today is hypoxia and cyanosis. A section on clubbing is also there in this chapter. Before I move on to discussion of hypoxia and cyanosis, look at the section on clubbing. The first thing is that the entire paragraph from Harrison related to clubbing is important. Initially, they have given what do we mean by clubbing. After that, they have discussed the various etiologies for clubbing. After that, they have discussed that clubbing in association with joint change is referred to as hypertrophic osteoarthropathy. How can it be diagnosed? Which joints are affected in it, and in which cases it is seen. After that, you should also know that clubbing is reversible in nature. So read this on your own. Let us get started with the first topic, that is hypoxia. Hypoxia is defined as a decrease in the net arterial oxygen content. This net arterial oxygen content is calculated using this formula. For this formula, it is imperative that you should get the ABG values. On this ABG value, when you get the PaO2 value, hypoxia is divided into two basic etiologies. Either this PaO2 value will be decreased, referred to as hypoxic hypoxia, or PaO2 value is normal, in which case you should consider stagnant hypoxia, histotoxic hypoxia, and anemic hypoxia. The chapter opening statement from Harrison states very clearly that for adequate respiration, you should have intact cardiovascular and respiratory systems. Along with that, you should have adequate number of red blood cells, normal functioning hemoglobin, and also normal level of oxygen content in your environmental air, in the inspired air. Along with that, I will add one more extra sentence. You should also have normal tissue oxygen utilization. This is also important, and thus when this is impaired, it gives rise to histotoxic hypoxia. Now let's get started with the first arm of this description, that is hypoxic hypoxia. So hypoxic hypoxia, it can be divided into, on the basis of the alveolar to arterial gradient, into two basic categories. Either it is normal or it is increased. If the alveolar to arterial gradient it is normal, think of two etiologies. Either it is related to hypoventilation, in which case the PaCO2 value will be increased, or the other scenario in which the decrease in the fraction of inspired oxygen will be present, which can be seen in high altitudes. Then if the alveolar to arterial gradient is increased, think of three basic etiologies, that is VQ mismatch, in which there is perfusion of under ventilated alveoli, or there is impaired diffusion like in interstitial lung disease, or the presence of shunts. Shunts are of two types. One is pulmonary, the other is extrapulmonary. Extrapulmonary means it is either cardiac in nature. It is generally cardiac in nature. So think of various congenital heart diseases, cyanotic congenital heart diseases. And in pulmonary etiologies, remember cirrhosis, because it will cause hepatopulmonary syndrome, AV malformations, and also hereditary hemorrhagic telangiectasias, which can also result in pulmonary arteriovenous shunts. In all these etiologies, except for hypoventilation, PaCO2 value will be decreased. Remember, for all of these various classes of hypoxic hypoxia, leaving extrapulmonary shunts, everything is correctable using 100% inspired oxygen, whereas extrapulmonary shunts, by virtue of their cardiac nature, they are not corrected by inspiration of 100% oxygen. So this means that when you give this 100% oxygen, SpO2 value does not correct to greater than 95%. So this is what you have to remember. Now the next part of this arm is when the PaO2 value is normal, in which case you should consider stagnant hypoxia or histotoxic hypoxia and anemic hypoxia. In the case of histotoxic and anemic hypoxia, cyanosis will be absent, and so will clubbing. Clubbing is also absent because tissues are not utilizing the oxygen. The venous oxygen content is increased, and thus this is the classic feature of histotoxic hypoxia. In stagnant and anemic hypoxia, the hemoglobin, either it is not having the enough oxygen, or because of stagnated blood flow, there is increased extraction from the blood, and thus this will give rise to greater than normal low level of the venous oxygen content. This is the defining feature on the laboratory assessment for hypoxia. Now, hypoxia has a lot of biochemical changes inside the body, so it will upregulate the hypoxia inducible factor 1 alpha, which will give rise to increase in VEGF and EPO. Along with that, it will predispose to cell injury if it is sustained, so it will cause a decrease in oxidative phosphorylation, ATP depletion will occur, and that will ultimately give rise to cell death. I will not discussing it in greater detail. The next section is hypoxia and the various changes that will occur in the body. So in this arm, just remember that hypoxia causes changes in all the three major organ systems of the body that are responsible for sustaining life. So CNS, respiratory system, as well as the cardiovascular system are affected. In the initial case in the central nervous system, there is cerebral vasodilation, but because respiratory system function is enhanced, the respiratory rate increases and PSCO2 washout occurs. Later, cerebral vasoconstriction occurs. So that predisposes, if it is very sustained, it will cause high altitude cerebral edema. In the other scenario, when respiratory and the respiratory system is also affected by the constriction of pulmonary arteries, which will divert the blood to better ventilated areas of the lung, but it will also increase the hydrostatic pressure in these areas, and thus starting forces will favor the extravasation of fluid, and that will give rise to high altitude pulmonary edema, HAPE. This discussion that is related to HSC and HAPE is applicable only for high altitude scenarios when the cause of hypoxia is related to high altitude. Now, in this CVS, remember, myocardial depression is the final effect. Initially, there can be some excitation, but the final effect is myocardial depression. Always systemic arterial vasodilation will occur along with venous vasoconstriction. Then the clinical features in any patient who presents to you with hypoxia generally has unstable vital signs along with impaired cognition and coordination. Along with that, the patient is agitated. Remember, when a patient is having hypoxia, agitation is present, whereas when the CO2 value is elevated, that is hypercarbia is present, generally the patient is obtunded. Along with that, when it is sustained, hypoxia is sustained, it will give rise to a papillary edema, headache, as well as coma can result. So this completes the discussion of hypoxia. Just remember, in high altitude, there are some values that are given. So at 3000 meter, high altitude illness will develop. At 4000 meters, cyanosis will develop. And at 5000 meters, HSC and HAP will develop, and that will lead to coma. Chronic mountain sickness develops in people who live at altitudes of more than 4200 meters, and in this condition there is a blunted respiratory drive. Along with that, there is erythrocytosis, that is due to increase in EPO. Along with that, there is cyanosis. There is pulmonary arterial hypertension due to chronic pulmonary arterial vasoconstriction, and that will give rise to right ventricular hypertrophy. So this is the basic discussion of hypoxia. Next is related to cyanosis. The definition of cyanosis is important. It is defined as a bluish discoloration of skin and mucosa, which is generally due to increase in the reduced hemoglobin to more than 4 gram per deciliter, or the presence of abnormal hemoglobin in the capillaries. It generally correspond to the SpO2 value of less than 85%, but in dark skin individuals, you should consider the value that reducing to even further, that is less than equal to 75%. The sites where you will look for cyanosis are generally lips, ears, nail beds, and the malar eminences. Cyanosis can be modified, it can be intensified, it can be decreased. So skin thickness, obviously, as I just described, it will limit your ability to see cyanosis. Then the cyanosis always is evident whenever the absolute quantity rather than the relative absolute quantity of reduced hemoglobin should be elevated. So that is why in anemia, even though there is marked increase in the reduced hemoglobin, because the total amount of hemoglobin is also reduced, you will see that the cyanosis is not present in anemic individuals. After that, venous hypertension, obviously, because of back pressure, more amount of reduced hemoglobin will pool down in the capillaries, and that will give rise to cyanosis. The classification of cyanosis is basically central or peripheral. The clinical approach is that if you are seeing cyanosis evident in both skin and mucosa, then then it is definitely of central etiology. If it is limited to the skin, and obviously when clubbing is absent, it is peripheral in nature. In central etiologies, it is either related to a decrease in the arterial saturation value, or it is related to the presence of abnormal hemoglobin. If there is peripheral cyanosis or there is abnormal hemoglobin, in both these conditions, clubbing is likely to be absent. Whereas if it is hypoxic hypoxia or stagnant hypoxia, in that condition, clubbing will be present or it will be absent. So I have written this over here. That completes this discussion. So in the peripheral cyanosis, just remember the mechanism is related to a normal CO2 value along with an increase in the extraction of O2 plus decrease in the local blood flow, and that can be caused by shock, by arterial obstruction, by venous obstruction, or cold exposure. Read the textbook for gaining more perspective, and that summarizes this discussion. Thank you.